Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter.
Hello and welcome, everyone. My name is Renee Garrett, and I am your SpeechTherapyPD.com podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEUs. Here are the financial and non-financial disclosures. Fred Stal receives an honorarium for his appearance on this podcast from SpeechTherapyPD.com, and he has no relevant non-financial relationships to disclose. Renee Garrett is a paid employee of a private consulting firm in the Commonwealth of Virginia, and she, as the host of Brainstorms, Functional Neuro Rehab for SLPs, receives financial reimbursement from SpeechTherapyPD.com. She also receives financial compensation for this and other webinars on SpeechTherapyPD.com. She is also an adjunct instructor for both James Madison University and Old Dominion University. Renee is the current secretary for the Communication Disorders Foundation of Virginia. Now, without further ado, we welcome our guest, Fred Stal. Fred Stal is a certified speech-language pathologist working in New York City and the greater New York City area. His initial training began at the Cleveland Clinic Rehabilitation Hospital, where he completed his CF. He currently works in the outpatient setting, part-time and per diem in the acute care setting. His clinical focus includes voice and swallowing disorders, including working with the head and neck cancer population. He recently collaborated with the New York University Swallowing Lab on novel research on modified barium swallow exams, bolus measurement, bolus clearance ratio, and related objective swallow parameters. He is interested in gaining additional experience as a clinician and researcher in both of these areas. Welcome, Fred. Thank you so much for joining us.
Thank you so much for having me, Renee. It's a pleasure to be here tonight with all of you.
Yeah, it's great to see you. It's been a couple of months.
Yeah.
I think we've all been quite busy.
Always busy, yeah. Getting a break is nice. It's a rare treat. It's part of the life we chose, right?
Yeah, the passion spark, and what's the theme? Ignite last year, elevate this year. I think that's pretty much a standard for career goals. So let's kind of just jump right in. And what would you say really kind of, and I say this because my background is also in acute care, and I spent a long time working with dysphagia and different reasons for dysphagia for the patients. And so I still don't consider myself an expert by any means. My background, like the area of expertise that I'm certified in, is brain injury. But talk to us about what sparked your interest in head and neck cancer.
Sure. It's really a very long story.
Well, good. I like the
short
long.
of it. Doing a semester in the hospital setting as a grad student, I realized there was a certain spark within me just being in there. I felt like it's just a different part of me, this passion that I didn't have for some of my other clinical rotations. And I had a great supervisor, and like a whole team of medical SLPs. So it was just that nice kind of team spirit, if you will, like a lot of support. I was never afraid to ask questions. And I had gone to one of the managers there. I took a diagnostics course with her, and she was kind of like the lead SLP for that team. And I was interested in learning more about objective swallow studies. And I had no idea this was even a thing, that I could do video fluoroscopy, fees. And so she had suggested to me to email Dr. Eric Blicker, actually. So I emailed him, like, I'm interested in volunteering. I already took a basic fees course with the great Queen Susan Langmore. Dr. Langmore is like my favorite, one of my favorites. So I went and basically was a nose, people scoped me, and just being there and getting some passes and getting scoped on, it really not only like helped me feel like the patient, like we're scoping and doing all these things, but I just learned a lot, absorbed a lot being in that environment. And I met a friend and mentor, Lori Wennerholm. She's currently going for her PhD through University of Queensland, and she's a real head and neck expert, I would say. I think the great ones are very humble and say they're not experts, right? But she took me on as a mentee. I did a mentorship with her, and I just found that we had a very pivotal, unique role as SLPs working with head and neck patients. I think other than obviously surviving disease, the next priority was quality of life. And that is a big part of that is eating and drinking again. And just, not only giving the patients a voice again with like the TEP patients, our total laryngectomy patients, but how are these people going to eat and drink again? And I think it takes a lot of knowledge to not so much take away from those patients, but give them somewhat of a life back. It's a very big new normal to take on after radiation, chemo, in some cases, surgery, chemo, and radiation, triple modality treatment. It's quite a lot to go through. If you ask any oncologist or oncology nurse, they'll tell you that head and neck treatment is by far the worst cancer treatment to go through, given the head and neck region, right? So it really was one thing that led to another, that led to another, that led me to meet these great people who kind of took me on, and I got some really good mentorship. So I'd say really through Lori, and then learning about Andy Anderson, and really big Dr. Kate Hutchison fan as well, and just her work. It's been kind of like an ongoing journey from there. The more I learn about it, the more I love it. And it just ignites more passion and interest in learning more. So that was the initial kind of what sparked my interest in it, was just being at the fees course and learning so much by just talking with really brilliant people.
Yeah, no, that's great. I'm kind of thinking on my feet here right now, because I think for me, it's such a nuanced thing, because there aren't a lot. I don't feel like there's a ton of people when it comes to just speech language pathologists who necessarily specialize in this. And maybe I'm wrong. I just haven't come across a ton of people who focus solely on head and neck cancer. It's usually more of a niche, right? So like for our health system here, we have basically one or two people who really focus on the, like you mentioned, all those other aspects like voice and TEP and total laryngectomy, swallowing, all those things. And then the other health system that's nearby me, it's the same thing. It's been the same person for a number of years. And there'll be people who come in and are interested in and maybe do like their CF, or maybe they do their early career first couple of years, and then they move on to somewhere else, and we're still with the same one person. So where you're at now, is there it's still a team of SLPs that are serving in this head and neck cancer population, or is it just one or two folks?
It's a couple of us. It's one in particular, a woman named Lisa I'm working with out of Atlantic Health. So I'd been with Lori for a little bit. My acute care job, we will get some head and neck cancer patients that come in, but really it's through the outpatient setting where I'm working in New Jersey, where we do get a lot of head and neck patients that come in, and their go-to person who I've been working closely with over the last year is Lisa DeMasi. She's been 20 plus years a head and neck specialist. So she didn't know so much about the lymphedema aspect of it. She did take the course, but I think what happens is we get so gung-ho and we take so many courses, we sometimes forget to apply all the knowledge we learn. And, it's a lot of other aspects to look at. And I think really the last 2, 3, 4 years, specifically with some of the research, we're realizing more and more how lymphedema, not just what we can see on the outside, but the internal lymphedema, what that research has shown plays such a pivotal role in functional outcomes. So initially it was all radiation fibrosis, which I think is such a big underpinning to those, complications, late radiation toxicity. You're essentially getting cancer burned out of your tissue. And with that comes, it's a different tissue afterwards. And again, hopefully you survive that treatment, but a lot of rigidity, a lot of loss of range of motion, your ability to even just turn your head over time gets impacted. So a missing link to that treatment paradigm, and I think it speaks to the importance of multidisciplinary collaboration, is the lymphedema stuff. Managing the external part, but even for patients that don't manifest with real external edema, they still have voice changes, they have internal swelling, and then there's fluid within the lymphatics, which I'll get into a little bit, but that kind of has nowhere to go. It's supposed to sort of flow throughout your body, and that can harden over time as well. So learning how to manually move that fluid and educate the patients on compression is something we've been doing more and more of, which I'd learned through some of my colleagues at NYU and through Lori. Lori and I had done the head and neck Norton course last January in Portland. So it was a very intensive course. And from what I hear, the CLT course, which eventually I probably will take and become a certified lymphedema therapist, is even that much more grueling. But, there's just always so much to learn. It's quite complex and overwhelming to think about. So, when you sort of look at the nuts and bolts of it, skincare, managing, you have desquamation, you have desquaming. It's like a sunburn to the skin. Managing the skincare, educating about compression and why it's important to wear compression to retain that fluid so it doesn't build up and get worse. And then manually draining that fluid through MLD, manual lymphatic drainage. So it's been a nice kind of teaming up, if you will, with me and Lisa, the veteran head and neck specialist. She does a lot of the TEP fittings, and then it's a lot of dysphagia therapy. It's a lot of education, and it's pointing those patients to the proper resources, social work, the mental health aspect of it that, again, I think there's just so much there that you want to know who to refer out to, because we can't do everything. Even though sometimes SLPs are expected to, we just can't do everything. So it's been a nice team for sure, but a small team right now.
Yeah, so I'm going to backtrack a little bit because you just brought up a lot of excellent points that hopefully I remember to get back to, because I think there's details amongst all of those things. So if I get lost, I'm counting on you to rein me back.
Please, and likewise.
So we'll start from the beginning, I guess, is a good way to go, is assessment. So for me, when I would get someone with head and neck cancer, it was a twofold thing. So when I worked in acute care, typically I would get them for modified barium swallow, like a snapshot in time as an outpatient. It was a one-shot deal. Sometimes people would come back 3 to 6 months later for a repeat. And then when I worked in outpatient, I would get patients who typically would have late-term radiation effects that impacted their swallowing and sometimes voice. More so swallowing was the bigger concern, but I'm talking like 10 years post radiation. So it wasn't something where I was getting these patients with acutely done with their treatment. It was like the late-term effects. So let's talk about assessment. Where do you start with this group?
Sure. Well, I guess some of the first questions, other than doing your chart review, is have you been eating at all? Are you completely NPO? If so, what have you been eating? Is eating and drinking a goal of yours? Just starting with that. Those have been some tough cases. Some people are afraid to eat again or were told that they never could. And so I think there's a lot of education just on that alone, let alone clinical assessment. And just looking at range of motion, is this a real late RAD case, really a real late RAD toxicity? Do they have a swallow function at all? I think an objective assessment is so useful, but I also believe that clinical swallow exam is too. There's so much we can infer that needs to get figured out even before the objective assessment, MBS, fees. So yeah, I would usually start with that. How can we help you? Is eating and drinking something that you would like? Have you had anything? When's the last time you've had a meal? And I would look at max phonation time. I like to look at cough strength. I think other than swallow function, I love a lot of the work out of, the upper airway lab at Columbia. Shout out to my New York people. We learn so much about swallow, but there are patients who aspirate and will aspirate for the rest of their lives who never end up with an aspiration pneumonia. So cough strength, I think, is very important in how I see through my clinical lens. And also, I love digest, through MD Anderson. Again, great work. I was just talking about this at DRS, swallow safety. We talk a lot about aspiration, but also efficiency of swallow. A lot of patients, really the underpinning of their impairment is the efficiency of their swallow, which then can affect the safety of their swallow as well. So I think about those things too. Can they move food from mouth to stomach efficiently? And obviously aspiration as well. I'd say a big benefit of being in the acute care setting is I have access immediately to lab work. I look at the CBC differential. I like to see white blood cells. I like to look at neutrophils. That tells me something about their infection risk. And again, pillars of aspiration pneumonia, Langmore, that research. So it's really calculating their risk, looking at how strong their cough may or may not be. I started an inpatient rehab, and what I liked that we used peak flow meters, which are relatively cheap. And I looked at some of the literature in pulmonology, and I'd like to see more literature within our field. We have some great stuff out there. What's the volume that they can expirate out? And if it's under 200, we're more concerned that can increase their risk, give or take between 200 to 300, moderate risk. But, if they're in that 280 and above category, correct me if I'm wrong, I'd have to look again at the literature, but that's more or less in my mind what I'm thinking of. That's telling me if they do aspirate, they can protect their airway.
Yeah.
I think that's.
And we talk about that a lot, or at least I have recently, because I think for so long we were so stuck on aspiration, but we weren't necessarily talking about how, again, like you mentioned, we have patients with head and neck cancer who chronically aspirate over their lifespan and they never develop aspiration pneumonia. So who are we to be the diet police and say, absolutely not, you're not allowed to eat or drink because we saw this little tiny millimeter of a particle go down into your airway that you were then able to cough, right? Cough strength, cough it out, swallow again, and clear it out. So I think that's a great point. I know I've seen that many, many times on those outpatient modified barium swallows who came in again to see me for a one-shot deal. Then on the flip side, when I went to outpatient and I would send my patients over because the facility I was at was newish, and they didn't have the capability yet for me to do my own swallows, which drove me nuts because I trained all the other people for the most part. So it's like, come on, just let me do the thing. But I would send them over and they would have this one little tiny micro aspiration or, very minimal on the first swallow, took too big of a sip or whatever it was. And it may not have, we don't even really know objectively what happened. They aspirated on the first sip. The radiologist is freaking out. And the speech language pathologist said, take another sip, and you never saw them aspirate again. But then they want to make diet recommendations for nectar thick because that looked better. And then when I go in and I look at it, it's but they had so much residue with the thickened liquids that they were unable to clear. And I feel like we're just in this catch-22 all the time of depending on who's doing the study, who's got I won't even say experience because that's not a valid statement. I know I've seen people with a ton of experience who are operating in this old style mode of thinking who would make that person NPO or automatically let's do honey thick liquids, or everybody gets a chin tuck, everybody gets a head tilt. And it's so incredibly frustrating.
So frustrating. I've had to really advocate for myself, especially as a very new clinician. I'm still relatively new for training. And, I've heard some people say, listen, I would love to train you because I don't have to untrain you. And I think we've had to come a long way in terms of coming from a place of research and informed decision-making and educating our patients rather than a place of fear where we're just taking things away from people that are so important to life, literally. So yeah, I hear that for sure. It could be frustrating, but I think it's important to have those conversations and, rather than a shame on you, there's this fear of, am I doing it the right way? I think coming from a place of humility, something I have to remind myself of, and to know, people with years experience. That's why, the person I work with closely with now, she wants to learn. She's always learning. And I don't want to ever lose that. It is a scary thing when you're dealing with the airway, when you're making decisions. My first day, on my own acute care, doctors are asking me, can this person be PO? And that's a big decision to make. So I can feel confident. A lot of pressure.
Yeah.
And I think people are afraid of that hypothetical scenario in their mind. What would you do if you're in this courtroom and you get sued? And I don't know many people where that's happened to them. I did talk with Karen Scheffler, she's doing some legal consultations. So there's so many different avenues to take as SLPs, but I think if you're documenting well and really being transparent in how you practice and what's going on, I just think we can make really good decisions that aren't limiting, but also protecting ourselves. But I know for me, I don't want to ever be that clinician that's coming from a place of fear and making the wrong choices for what my patient truly wants, and hopefully would be able to do, like eat and drink,
Well, and I think too, when you look at like you said, the shared decision making, we have a responsibility to provide all of the avenues and what that education piece looks like as far as risk, but also respecting. I mean, I know I've had patients who are like, I don't care. Like this, I've been through the worst. Like you mentioned, the triad of modalities of surgery, radiation, chemo. I've been through that. I have this now. And if I want to eat a crab cake on a Friday night with my spouse or my grandkids or whoever it is they want to hang out with, yeah. My last really big case that I had, he was coming to me and we were doing swallowing exercises, but they were talking about pulling out he had been peg tube dependent for about a year because he had some complications. When he completed radiation, he was having some bleeding in his oral cavity and lots of course, xerostomia and that kind of stuff. But he had pretty significant lymphedema, and he actually went to PT for the management of that. And then just a lot of medical complications that he had. But what he started doing on his own, because it was taking so long for his physicians to respond whenever we'd put in an order request for a modified barium swallow, he started saying, you know what? I haven't been sick in a while. I never had aspiration pneumonia. I've never had pneumonia at all. And he was in his 70s. He's like, I'm going to see what I can do. And then he would see what he could do, and he'd tell me about it afterwards. Because I think he was afraid I would kind of be like, no, you cannot do that. But he came in and he's like, hey, I got to tell you something. I had scrambled eggs this weekend. And I'm like, okay, well, how did it go? How did you feel? What were some challenges for you? Or do you feel like it went great? So he was able to kind of describe that he felt like it was stuck. We knew that he had molecular residue from previous swallow studies, and effortful swallow, double swallow wasn't effective for him. But he would say, well, if I clear my throat and then I swallow, I feel like I can clear it up. And the other big thing for him was he would say, if I take too big of a bite and I don't chew it well, and I said, but that's for everybody, right? And he kind of would chuckle, and he had a really great sense of humor. And so I wasn't going to ever tell him, don't do that, because he was fine. He was doing great. And my biggest thing for him when you're thinking about barriers was I didn't want for him to go to the doctor and they pull the peg tube out before we had the repeat instrumental in case there was something really catastrophic that could put him in danger of airway obstruction. His cough was actually freaking great, for lack of a more professional term.
There you go.
Yeah. And he had been working with EMST, the strength trainer at home, for a little bit. So yeah, but just thinking about like barriers for treatment, I think that's when we think about our head and neck cancer population, a lot of times it is medical complexities and complications that occur as a result of the treatment. So can you talk a little bit about that?
Just the medical complexities in general?
Or just some of the things that can happen as a result of chemo and radiation, sort of in that immediate post-treatment phase?
Yeah, so generally, patients that I've worked with, there's more oropharyngeal cancers, above the larynx. We're thinking base of tongue. We know we need that for swallow efficiency, and really swallow in general. It's like the power driver of your swallow. There comes a point where counseling needs to happen. Ideally, we want to get someone in before they even start radiation. We want to teach them the standard head and neck range of motion, effortful swallows, just getting them acclimated to what like prophylactic exercises really look like as far as dysphagia goes. And then I'm a really big fan of head and neck cancer support groups. I know sometimes that can scare people at first, but they really need each other. And I think that value of them helping each other, be like, I've literally been through this too, is so crucial. So that would be the most ideal situation. Not everyone's completely on board right away. And honestly, they're just overwhelmed with the treatment they have to undergo. And there's a cumulative aspect to radiation. In the first week or two, not too bad. The last couple of weeks, once you're about midway, that cumulative effect really starts to hit you and you feel like you can't make it through. And I think that's when you really need to be there as an emotional support. And that's usually where you have such pain when swallowing because of that treatment that at that point, then, alternate means of nutrition and hydration are warranted. And then you would counsel them, well, this isn't a forever thing, but it's, we're going to try to get you back to swallowing as soon as we can, because we know from research, definitive, good, solid research, the sooner we start doing it. And at first it's going to suck, for lack of a better term, but you have to sort of suck it up and do it so that it'll be easier later. The you in a year from now will really thank you now for, sticking it through. And it can be tough. And the other thing too is just the dysgeusia. There's a change in the pH in your mouth. There's a lot of talk in the scientific literature about the gut microbiome. We have a microbiome in our mouth too. It's all really one continuum. And, as the pH changes, the taste changes too. And a lot of people will find things, especially that are acidic, are like rough. Like I've worked with some really tough guys who are head and neck cancer survivors who, thought that they could have a cup of orange juice and thought they ended up, they'd have to go to the hospital because it was so just raw and painful to have anything with any acidic quality to it. So those are some of the challenges. I think this really is hard. I don't feel like I'm going to make it through, and food and liquids just don't even taste that good anymore. And that's when somebody who's been through it, who's a year or two out or more, who can say, because they might not believe me, but you will get some taste back. In fact, you might get a lot of taste back. And it's sort of that motivation to really push through, especially when you need to really push through. It's very hard, but that vigilance is so important. So those are some of the complexities, because who wants to be punted around to this specialist and that specialist? And it's a lot, and I think there can be a lot of just exhaustion going to so many appointments for so long. And so I try to keep that in mind too. We want to save the world and do it all. And like I said, referring out is so important, but really giving that education and preparing them in a way that's hopefully not going to scare them too much, but prepare them mentally and emotionally so they can get through it. These are some of the things that are as important as the clinical interventions.
Yeah, no, I think that's great. So, psychological barriers, pain barriers, sensation change barriers, and then fatigue, like you mentioned, activity tolerance, because it is exhausting to not only the going from appointment to appointment, but just the treatment in and of itself is physically exhausting and also mentally exhausting. So I think those are all really great points because, yeah, I'm thinking about a couple of the patients I saw back right before the holidays, and for them being able to come, because there was one guy that was going to treatment 5 days a week. And then for him to be able to, and I'm being pushed, from a productivity standpoint to have him come 2 or 3 times a week. It's not feasible. He couldn't physically do it. And, they had a transportation barrier because they were coming from a city a little bit further away. It was about a 40-minute drive one way. And then he started with like nausea in the car, and, the pain was there, like you mentioned. And there's a lot to be said for having that supportive network behind you that may or may not be like your immediate family and friends who aren't necessarily going to understand what you're going through. And we know that the literature supports support groups for a lot of different populations, but specifically for this population. And so I think those were all really great points that you made. And thinking about the patients that I've seen because I'm not lymphedema trained. And so typically what I would do, like, again, you mentioned, is refer to someone else, because I can do the swallow piece of it and the voice piece of it, but I cannot do the lymphedema management. I'm not trained in it, not certified in. And so I never felt comfortable, confident in portraying anything, but other than that. And again, that's one of those things where there's nothing wrong with saying that. You need to refer. If it's not for you and you don't have the capabilities of doing that, we're ethically responsible to refer. So
Sure.
I kind of want to jump into that and just the lymphedema management without, you can be as technical as you're comfortable being, but I don't want people to think that then they can go back and say, oh, well, I heard about this lymphatic drainage and now I'm going to try it. Don't try it. Don't try it without the appropriate training.
I think for me, the hardest thing, I'm thinking manual therapy. I took a great course on that, and I love massage personally. This is like all about a very gentle tug to open up these, filaments of the lymphatic system to allow the fluid to move. So it's a very specific sequence and it's a very specific level of pressure. So definitely don't try this just yet till you really get trained. And We did spend a lot of hands-on time. We learned through Christina Porsche, who was absolutely amazing. She's also out in MD Anderson. And they had an OT come in and help. And something that the OT said, and I just love being able to collaborate with other disciplines. She said, don't ever discount yourselves, because really we are the swallowing experts. We should be. And I think that it's easy to feel like our scope of practice is one thing when really I think it's still evolving. I think as a field, we are actually still an embryo. I don't even think we are, quote someone else who said that, but it's the baby stage, but really the embryo stage. So that being said, part of the swallowing intervention paradigm should involve us doing lymphedema therapy, especially for these patients. And we do have a lymphedema unit where I work, and we have PTs, and it's been really great. But I will spend time, when someone recently, some patients who've had their peg removed, they're eating, I'm working with them. They've got a good handle on what their home exercise plan is. We'll work on trismus, which I really didn't get too into, but that's, inability to really open your mouth to be able to eat. And again, this is an effect of the cancer treatment itself. So using devices, whether it's a TheraBite or a stretch, passive jaw range of motion, there's so many different things we could do with and without devices, but it's important to do all of it and for us to own our role so we can refer out, but to not be afraid to learn new tools that we can do. And I absolutely believe we should be managing lymphedema as well, especially for not so much mobility, but the head and the neck and eating and drinking specifically, as well as voice, because that internal edema also will affect vocal quality. So I think there's some good research out there. We should look more at voice and swallowing and how that can change before and after, treatment of the lymphatics in addition to your standards, swallowing protocol. So there's the manual lymphatic drainage, and it can all feel very overwhelming. But what I like about outpatient is I've been able to work, like there's one gentleman in particular, it took 4 or 5 months. He thought he would never get a peg taken out, and it was taken out in December. And we just were able to just focus on manual lymphatic drainage and trismus, and he's doing great. And it's a complex case because there's other factors. There was, he did end up with infections and aspiration pneumonia. These are the types of cases where, I think it'll scare any clinician, but oral care, just brushing your teeth, don't ever underestimate the most simple things that can go such a long way. So yeah, these are all things for us to think about. And I don't think any of us, maybe some of us learned the proper tools in graduate school, but I had to seek the mentorship and be a total nerd and read research and then ask questions and be willing to look dumb so that I could really learn, because, I think the more you know, the more you realize you don't know. So there's just so many aspects to think about.
Well, and I think it was Dr. Ashford that was telling me that I think it's the UK, they have a newer evolving profession where it's not a dental hygienist, but it's someone who's trained as I forget what the terminology is exactly, but they basically are trained to do oral care within different settings like acute care. And that's what their job will be. Just like and this was before your time, but used to in acute care, they had phlebotomists and their job was to draw blood. Like that was their specialty. And I worked with someone who she was certified within the state that was what she did. That's all she did all day long. And I mean, you could go behind her after she was done and there was not a mark on that patient's arm. I mean, she was great, like fantastic at her job and like trained. Was her life's work. I don't know about you, but when I go for lab work, I'm not really afraid of needles, but I'm afraid I walk in and I'm like, oh, I don't know that person. This is not going to go well. They don't look like, I saw that old guy that came out and his arm looked like crap. And so to think that there could be someone potentially who is specifically trained in oral care and that's their role specifically in a hospital setting would be fantastic. I love nurses. Most of them don't have time and they hate oral care as far as performing it. I laughed not too long ago because OTs, they have no problem with like cleaning up a bowel movement, but they do not want to get in anybody's mouth with a toothbrush. The opposite is true for me. I made a joke not too long ago about that during the pandemic with all our gear when we had all these layers of masking and stuff. I was like, yeah, I can get those dentures clean, no problem, because I can't smell them. Because there's nothing worse than you get called down to the ED and it's like these dentures that have been sitting in someone's mouth at the nursing home for months and you pull them out and you're just like, oh, I don't want to die on this
The word.
hill.
Yeah. Yeah.
But it's so necessary because we have, like you said, there's so much literature and everything else to review that we don't even really have to review it. We just know that the literature is there that says oral care is paramount in so many different disease processes and preventing future problems and issues, but particularly for our head and neck cancer patients. And one thing I think you mentioned too about counseling, a lot of the time, what I've seen with patients who maybe have poor dentition or have some infection present or even like cavities, tell me what they do to the patients before they start their treatment. Because I think this is not widely known unless you've worked with this population.
Oh, absolutely. Again, it's like the most simple things that go a long way. I think it was last year, it was my first DRS, and there was so much talk about the clinical profile of these patients and really sciencey stuff, regression analysis, research design, all the different medical subsystems. And then Dr. Langmore comes up and she says, well, I hope you have considered brushing the patient's teeth, and like walked back to her seat. And it was so brilliant and so true. And like, if I had $1 for every time I've had the discussion just about when a patient will say, I do brush my teeth, but they mean they soak their dentures and there's just a lot of debris and a lot of bacteria in their oral cavity. Nope, soak your dentures, but there's a whole lot of surface space here that needs to be cleaned, and multiple times a day. Just positioning yourself upright, cleaning your mouth, working to fatigue, swallowing, getting those muscles going can work wonders. Very, very simple stuff.
Yeah, because what happens is if before they have any kind of chemo radiation, a lot of times what the surgeon will have done is removal of the teeth that are remaining. I mean, I'm sure you've seen that, right? Where they go in before their treatment and someone who doesn't have good oral care and they'll remove the teeth that are remaining prior to their treatment. And I don't know if that's just unique to my area because it's more rural, but I've seen that a ton of times. And you talk about, that's like devastating because that takes a long time to heal. And if you're jumping somebody right into chemo and radiation where we know tissue's going to be impacted, that's going to be a challenge for that tissue to remain intact. And so then you start looking at things like deterioration of gum tissue, but also bone.
Correct. And there's also the chance of osteoradionecrosis and other complications that, again, going to some of the head and neck summits, we'll talk with, oral surgeons, dentists who are on par with us. And so, I think unless you speak that language and think about that, these are things that might not even get considered because, again, there's, especially nowadays, only so much time to do your job as a healthcare professional. And we're sort of thinking in a silo and so specialized that we're not zooming out and looking at the bigger picture. That includes oral health and possible complications like what you just mentioned. That's a very good point. I know some places will protect the mouth with dental guards, but other places that some big names that don't for whatever reason. So I'm wondering, is that something to look into? Could we standardize care to protect oral cavity more? That's a very good point.
Yeah. And when you think about like the osteonecrosis, can you talk a little bit about that and what the risks are to the patient other than just the death of the tissue when we're thinking about bone structure?
Yeah. So that's an infection that can actually cause other complications, possibly death, heart problems. There's a link, whatever is in the periphery is in other parts of your body as well. And so this is not something, it's not just like, okay, from an aesthetic point of view, not having your teeth or having things not be quite how you want them to be, but really it's very important for overall health as well. And it's one of those things that while it can be rare, it's still a possibility. And, for those patients who've had a history of oral health problems, who've had teeth removed, who maybe have certain exposure in their gums, that's something to consider that should be discussed with the oncology team prior to treatment for sure, because there's, you have to stratify risk and figure out who's more at risk of these kind of complications.
Yeah. And one of the people that I had, he wound up having just his jaw was so demineralized that he wound up having a fracture in the mandible. And it was just related to the treatment. There was nothing that happened. There was no trauma. There was no fall, nothing like that. It was just strictly, and we had to put a pause on the range of motion exercises because not only was it painful, but now we have this mandibular fracture that we can't really work on range of motion for the jaw when he's got to heal this fracture. Yeah.
Yeah. And that speaks to the importance of like, these are complex patients. And, I think some of the opportunities out there, it's like having the right mentorship so important because, who's going to be trained to even think about that? And that's why clinical experience is so important. Like what you just described. Yeah, that can happen. And it's like, I was planning on working on this, but we got that to deal with instead. And it does happen for sure, especially with this patient population. You want to get in there and save the world and get the range of motion exercises, and you have sort of your plan, but the idea of like heuristics and clinical bias, like there's other factors that we have to think about. I think the more you realize there's room for a complete left turn with something like what you just described, it'll help you be more prepared because you just never know.
Yeah. So let's jump back to lymphedema management because you mentioned going to training. You mentioned sort of this I don't know if it's not really a co-treat, but like observation and mentorship with physical therapy too.
Yeah.
So how do you kind of determine who does the lymphedema management, or does your system kind of utilize both?
So the system utilizes both. I wish, more places had a lymphedema floor. We do have it. I'm trusted with my coworkers and my manager, but I think, some SLPs would rather refer out because we can. Whereas for me, I brought some of these articles here. Just we see so much more how speech pathology, particularly, like we want to look at the whole picture and part of the clinical assessment. Other than you're back to your original question too. If there's external lymphedema and there's a clinical profile where like, they have lymphedema, we want to get in there and get measurements beforehand, measurements of their head and neck. You can usually see it a lot in the jowl region. And, we'll measure their entire head and neck and write down those measurements. And that's part of the protocol that I was taught and a lot of education. And then we go in there, and other than the swallowing therapy, we'll get in there immediately. We'll have them get, head compression. There's these Jovi wraps, there's Epstein garment, and there's ways to even make stuff on your own. And what I loved about our instructor, like by being crafty, I mean, people don't want to spend another $200 on some wrap after it's financially toxic, let alone radiation toxicity is toxic, just financially going through this type of thing. So looking at what kind of edema it is. So again, our lymph system, the lymphatics, it's tied to our immune system. Think of it as like a filtration system within the body. We have fluid that carries these immune fighting cells. That fluid, if it's zapped with radiation, or the other thing too is cancer does travel, it can metastasize through the lymph node. So it's these little bean-shaped cells. It creates this sort of dam effect where after surgery, that fluid is just stuck. And without help for it to move out to the thoracic area and out where it's supposed to go, it needs that help. So these are all things you want to consider. You want to measure in advance, and then you want to get in there and do it. And then ultimately you want to teach, hopefully, the patient has a spouse and family that's going to help with follow through, because it's a lot of steps. I think even for the practicing clinician, it's a lot of practice to get down pat. But again, it's just so important because it can help the fluid to move out as early as possible. So if it's a soft kind of edema that either pits, like if you press on a fruit, and there's non-pitting edema, and then there's more irreversible edema where it's at that stage of what we would call fibrosis, which is technically irreversible, but you can make these cherry packs. You can use like garbanzo beans or, some sort of hard nut and put it in like an ace bandage wrap. You can make your own little pack, and it can go under the compression garment, or you can use these chucks that sort of help push the fluid a little bit more, in addition to just the compression that will help retain or hopefully reduce some of the fluid. It'll help it from getting worse. Generally, people will say they wake up where they feel a lot of tightness, and oftentimes that's the lymphatics. So there's things you can do to kind of soften the tissue manually with compression, using a cherry pack, using, I could show you the diagrams, but there's a whole lot of crafty things you can do that can really go a long way. So I think getting the buy-in is important, because it's like, whoa, what are you talking about? I have to wear this weird thing in my head. We had a head and neck cancer survivor who was a federal agent who came in during our course and talked about, again, really tough guy. And, he had to like fly on these flights to DC, and he had like a gun, but then he'd wear this like black face garment, and, people were a little bit afraid, and he was kind of like, self-conscious about it. But, altitude changes, there's a lymphatic washout that's supposed to occur when we go to sleep. So, sleeping with a certain level of elevation, having that compression, especially in the earlier months, is just really important for managing it. Because I think timing is so important. Just like when we think about late radiation, over time, this toxicity can get worse and worse and worse. The same holds true for the lymphatic fluid. Those protein-rich cells get harder and harder over time, and to essentially create interstitial edema and fibrosis. So the earlier the intervention, the better, go figure, right? So these are all things that we want to get into early. And I think what a PT or OT may not always, they might not get the swallowing education that we have. So I think not being afraid to get educated and do it yourself, but also at the same time, when you need to refer out, you refer out too, if you're able to. But a lot of times we're sort of stuck having to do the whole thing. And what's beautiful is just the lymph drainage alone, suddenly their voice quality improves. Suddenly their swallowing gets easier. Their swallow efficiency scores are higher. They do better. It's like magic, and it seems a little woo-woo when you're learning it and doing it, and then you're like, it really works. And it's very rewarding because to see something that works so well, even within one session. So yeah.
Yeah, I felt that way when I did and this was not just necessarily for head and neck cancer, but I did the Walt Fritz course on manual therapy. And I remember going to that thinking, and this is what I do. I don't get all up in people's business. I mean, I get all up in your business and brush your teeth, but like to be like touching people and doing all the things and stuff. It was a lot. I think a lot of SLPs are not thinking that we're going to be so physically hands-on like that. And it was definitely
Sure.
getting out of my comfort zone. But once I finished the course, I was really lucky because I went with a couple people from my health system, but I also had a couple people that I knew in the field who were far more seasoned, and then a couple of students that I knew who got to go. So we were all there, and we could make some probably inappropriate jokes about some of the things that we were doing, but it kind of lightened up the mood so that we didn't feel so uncomfortable and out of our comfort zone. Because really, it's not, again, if you're looking at shared decision making, it's really not about us, but you do have to kind of get out of what you're used to and what the norm is, right?
Absolutely. I think I've been told it's a benefit being like, within your first 3-4 years as an SLP. But again, if we are still an embryo as a field, we're in that stage, there's a lot to learn. I loved that manual therapy course. And, again, people know what's going on within their body. Sometimes we can help them find it, but really, sometimes as a clinician, it's helping people break down the barriers to help them help themselves too, through education and through empowering the patient. So yeah, it's a little bit like, I didn't learn to do this, but some of the muscle tension dysphonia patients or people who have voice, and again, like there's a lot of manual therapy that comes with just doing, the MD Anderson protocol. They're turning their head left, right, up, down, they're opening their mouth. I'm going in there. I'm, really trying to get in there and getting into oral cavity and massaging and stretching. And so these are very important tools that we got to get up and get in there, get down and dirty. Yeah.
Yeah. It's definitely different. I mean, and even when you think about, like you mentioned too, the benefits to voice, always amazed at the people who still don't make the connection between voice and swallowing, and the fact that your vocal cords do both those things. Like they produce voice, but they protect your airway when you swallow. And that was where my handy dandy $40 larynx from Amazon came into place on my desk and outpatient, because you mentioned buy-in earlier. A lot of times I'd have spouses or family members come in with the patient, and they're looking at me like, she's so full of crap. And I could pull that out and pull it apart and be like, but here's what you're looking at anatomy wise, and break it down into the simplest of terms. And once you do that, the patient and their caregivers tend to be like, okay, some stuff.
Yep. Yep.
But it's important. Let them touch it, let them hold it, and then they can, try to feel on themselves where they feel that tension, whether it's, temporal, mandibular, if it's, in more than laryngeal spaces. Once you do that, show them the anatomy and then have them feel it. It's a whole different ball game.
Definitely. I feel like I should get that for my outpatient patients. I've been using this app, when I took my MBS IMP course, and there's the dysphagia app. So I'll
Yeah.
show the normal swallow, and then this is what can happen. And it's a nice visual, but I think that's a good one that you have. I should get some more tools that can be part of my education,
Yeah.
It
Particularly
helps.
for
It really,
the geriatric age patients, they seem to really like that model of the larynx. I don't know if it reminds them of their schooling or if it's just the ability to be able to touch it.
sure.
I don't know. I don't know what it is, but it seems to be great and it's not expensive. So,
Tangible experience. Yeah, it goes a long way. Absolutely.
yeah.
Yeah. But I did like the manual therapy course. And I think, thinking from a holistic perspective, thinking about we're treating the whole person, we're treating the body, you know, are there range of motion issues? Is there rigidity going on other than actual physiological issues with the swallowing function? These are all tools that are important, and often people might have their own intuition about themselves and know, and they just need the proper education and proper guidance. But I certainly hope more clinicians are willing to be hands-on. Exercise is an important prescription to dysphagia therapy. Eat and exercise, exercise and eat. Mobility, brush your teeth. I enjoy taking my patients out on a walk, especially when I was on call on the weekends. Patients wanted PT. I'm like, all right, if they're a moderate fall risk, or if I get the okay from their PT on a Friday, I'm going to walk with them and do my therapy too. Not everyone would do that, but I think it's good to think outside and think about mobility as another really important factor, actually. So,
Well, yeah, we could, because again, if you're looking at moving lymphatic tissue or moving lymphatic fluid out of tissue, moving around, go figure.
that is exactly right. It's almost like everything's connected, you know?
Really? No, I'm kidding. Yeah, your head bone's connected to your neck bone, that kind of thing.
Oh my gosh, that's right. It is. Hopefully. But yeah, I think, the trismus part too, it's like that was the last thing that my most recent really complex head and neck patient had was, it was hard to open his mouth, and it was getting worse. I think having a device and having some consistency, because he's only seeing me once, maybe twice for a 45-minute session. So just the consistency of having a device or having diagrams and having follow through at home is important. To hold the stretch, and they should feel the stretch. It should feel like work. If it's too easy, you're not doing the job that you're supposed to do. And, just by eating, that's going to help maintain somewhat. But I saw a huge difference just within a matter of a few weeks. And because this is, a patient that has a lot of other medical complications, I'll just leave it at that for now. I needed to kind of motivate him to want to do it. I think he was really happy and couldn't believe that he can eat again. But I'll tell you this, I think I was more excited than he was. I do.
Yeah, I think sometimes that's the case because, again, kind of going back to the support group piece of it, those patients often will feel like they're the only one and they're alone, where we have seen, a lot of different people throughout lifespan and throughout career. And, we've seen kind of the worst of the worst. We've seen the people who don't survive, and we've seen the people who
Mhm.
Are very young and maybe have issues with dysphagia for the remainder of their lifespan. And it's really impactful, I think, for clinicians, because then, we do get so excited and we are so motivated by those cases where we do see success. And not it, I think one thing I don't want to misrepresent is it's not necessarily our success that we're feeling. It's the success of seeing this person get back to quality of life and doing
Yeah,
something that's so basic but so meaningful to them.
absolutely. Absolutely. I think it's not until you have something taken from you that you realize what a gift it is. And it's a corny thing, but it's true. These aren't things that you necessarily appreciate until it's gone. And so to be able to restore that, I know for me, I think food is such a big part of life and comfort and culture and, just bonding with other people, that, it's just a really nice thing to be able to give someone back, to help them get back.
Yeah, for sure. I mean, you were just at DRS in Puerto Rico. How was the food?
The food was fantastic. So we were in San Juan, and apparently there's like 3 different places that claim to be the originators of the pina colada. Of course, the hotel we stayed at claimed to be the place that was the original, but that usually happens. You have 2 or 3 contenders for who was the original. And the dish that I think their most popular dish was mofongo. Correct me if I'm wrong. It's plantains, and usually there's meat in it, and it's absolutely incredible. What was difficult, again, I was learning so much and getting to meet some of my like real SLP heroes, which was cool. And I was copiously taking notes because last year I was so overwhelmed. I felt like I just didn't really learn as much as I wanted to. But seeing like a beautiful ocean outside, it's nice, but it's also like, man, it would be nice to be outside. So just to get to have had a little bit of that outdoor time was really nice. And I think it is a real community. I think I feel a lot more a part of. I think it could be overwhelming when it's your first time versus your second or third. But yeah, the food was absolutely fantastic. Whenever I travel anywhere, I try to eat the food of the region. So mofongo was one of those foods, no question about it. And then Old San Juan was fantastic as well. Just a lot of culture, street art, going out and hanging out, it was just really beautiful. Very artistic place. I do recommend they should have DRS there again. And we should go out and explore a little bit too, amidst all the learning and connecting with other, clinicians and research scientists. So
Yeah. And it definitely does give you a perspective for our patients. And, I think for most cultures, food is definitely central, and being able to get back to that when you've had such a devastating course of treatment and illness. It's because oftentimes that is the bigger part of it is the course of the treatment that's so much more impactful than, some people come in and they have very minor symptoms, if they have symptoms at all, before they find out they've got cancer in that head and neck region. And so that part is usually the most devastating, is the treatment. And so to be able to get back to that central love of eating and community with food is very important.
absolutely. And just being restored to some sense of being a human again. And again, I think, breathing, eating, talking, these are the essential features of what we do as human beings. And I think sometimes when we're so busy working and, tired, that we forget what an important role we play. DRS is a Dysphagia Research Society. I think someone had a question.
Yeah, I was just gonna say that.
Okay.
Yeah, so it's international conference.
It's an international conference.
Yeah.
I think this year was the first time it was out of the United States. Last year it was in San Fran. Next year, I believe it's in Philadelphia. So you guys should go. It'd be great. It's really a great learning opportunity. And you realize how much you don't know because there's such brilliant minds there that I just try to soak it all up like a sponge. So.
Yeah, I just came back from our state conference, which is not nearly the magnitude of that, but it's still, there's a lot when you, because I'll say even at ASHA, fangirling or fan guying, whatever you want to call it. When
Right.
you've read someone's research and you follow their work, and then you get to meet them, and you're like, oh, and then you realize they're just human like you, but they're just
I try to play it
smarter.
cool. I try to play, I think the first time it was clear that I was fanboying, I don't know. But just really playing it cool. And some of these people can end up becoming friends and mentors. We're all just trying to do the best that we can. I do have a funny story. Like, I really wanted to meet Dr. Hutchison, and, we like follow each other on social media, and I love her work so much. And all the MD Anderson people are fantastic. She was presenting a poster, and for one of her colleagues, she was on the paper as well. And then Ed Bice and Chris Galick came by and they were like, "Oh, are you on this paper?" I said, "I wish." And they're like, "Well, why don't you present it to us?" So then Kate was like, "Yeah, go ahead, present it." She overheard. So I'm like, this is how I'm meeting Dr. Kate Hutchison. I'm presenting her work to her. So I did. I tried to present it and winged it, and it was awesome. It was just a great first introduction to like certainly one of my like research and clinical heroes, and she was a sweetheart. But it was a really funny moment, one I definitely won't forget. So these are the types of things that can happen at CRS. So
Yeah, that's great. That's great. Yeah, I know Ed, so he's a good human. Yeah, fellow
he is a
Virginian.
really good human.
Yeah.
That's right, fellow Virginia. Congratulations. I just want to acknowledge that you were recently awarded as a fellow in your state. Is that correct?
Yeah, thank you. Thank you for that. I
So
appreciate it.
no, that's a very huge honor and well deserved. So I
Yeah, it's
know
very humbling, very humbling.
It's fantastic. What an honor, you know?
Yeah. Yeah, thank you so much. But I think this was a really good presentation to to really cover some basics and definitely some more intermediate, I think, topics too. But I really appreciate, Fred, you joining us and being on the podcast and just talking about so many different aspects, because it's hard to cover everything that we need to cover. But I think this was a great overview. So I appreciate you being willing to share your knowledge and your expertise. Thank you again, Fred. It was great to see you, and we look forward to seeing you again.
Yeah, Renee, this was so lovely. Thanks so much for inviting me to do this. Let's definitely do it again.
Sounds great. I'll be in touch.
Okay.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Thank you for joining us at today's podcast. Remember to go to speechtherapypd.com to learn more about earning ASHA CEUs. We appreciate your positive reviews and support and would love for you to write a quick review and subscribe.